Hi, my name is Dr. Al-Husseini and I'm going to take you through doing a cardiovascular examination in the next few minutes. Is it okay if I can examine your heart?
Yes.
Thank you. Can I rest you back?
Yeah, definitely.
Okay, so in a normal examination you'd like the patient to be fully exposed and probably cover them with a sheet, but however in this case we're okay to proceed. Take a step back and just observe the patient as to if there is any obvious abnormalities with the patient, if there is any other equipment surrounding the patient, or if there's any medications the patient may have by themselves, which will give you an indication of what's going on. All right, are you comfortable, sir?
I am.
May I just open up? And the first thing that becomes very obvious is that this gentleman has a scar on his chest, which indicates that something is being repaired or replaced. For the sake of this examination, you'd also want to examine his legs. And if I can pull up your trousers, sir. Okay. Happily demonstrate that there is no scars on the legs here to demonstrate that this gentleman has had any venous harvesting for any bypass surgery. May I have a feel of your pulse? Okay, so examine the hands is very important. So we're looking at nail changes that may be associated with cardiovascular disease. And if I can turn your hands over again, we're looking for any lesions or any suggestions to suggest there may be any infections. I'm just going to have a feel of your pulse. If you can rest your hand there for me. Okay, so I'm feeling the pulse here for the regularity and whether the pulse volume is normal or abnormal. And I like to always do this is feel both pulses at the same time to just make sure there isn't any other cardiovascular abnormalities like a coactation with a radial delay. Okay. What we're going to do here is show you how to do a collapsing pulse. Again, this will vary and everyone will have a different technique, but I'll show you my style, which always works for me. And I guess what I'm trying to say is find something that works for you. So the way I like to do it, so if I can expose your arms there, do you have any pain in your shoulders before I start? No. I tend to like to feel the pulse, just palpate the pulse, so don't press it too hard. If you press it too hard, you will occlude the radial pulse. I use this arm, which is my supporting arm, to lift the arm up. Okay, so I firmly grip the arm and I lift the arm. Okay, and what I would expect in a collapsing pulse is that the volume of the pulse becomes much more boundy, and that would suggest that this patient may have an increased hemodynamic circulation, which isn't the case here. Okay, we come to examine the neck, and I normally take a step back just to look at the veins in the neck and whether there is any suggestion of increased venous pulsation to suggest a high JVP. Okay, I'd like you, sir, to look that way for me again. So then you can further demonstrate this by pressing on the patient's tummy to see whether you can bring up the JVP, which I can just see at the base of the neck here. Thank you, sir. Okay. Also feel for the pulse. Okay, so this is the time where you can feel for the carotid pulse again, which is a central pulse to see that the pulse is regular and of good volume, and also to assess if there is any other abnormalities that may be associated with valvular disease such as aortic stenosis. And again, I like to do it on the other side just to make sure that there isn't anything else that I am missing. May I ask you to take your glasses off, sir? Okay. If I can get you to look up for me. And then look down. So here we're looking for jaundice and we're looking for anemia. And if I can ask you to stick your tongue out for me, sir, and all the way to the roof of your mouth. And again, we're looking for signs of jaundice or any other cardiovascular disease manifestations that we can see through visualization of the mucosa. At this point, I always like to set my patients forward and ensure that I'm not missing any scars that may be on the chest. For example, in this gentleman, he has got a right thoracotomy scar, which may not be related to any cardiac abnormality, but however, it's very important to ensure that you don't miss any scars on the back of the chest that may be related to previous cardiac surgery. Okay, so let's put you back. Okay, fine. This is a bit where you come to palpate the precordium to see if there is any abnormality, and I'm just going to palpate over your chest there. Okay, so what you're doing is a quick palpation to feel for thrills and heaves, which may suggest that there may be an underlying cardiovascular abnormality. And I tend to do 4 corners, 1 underneath the apex, 1 over the left sternal edge, 1 over the right sternal edge, and then across the aortic and the pulmonary area. Okay, excellent. Right, so we've done our palpation, now we've come to auscultate, okay? Again, it's very different with everybody. I like to start from the apex, you may want to start from somewhere else, but as long as you know a system and you stick to it, that's the most important thing. All right, so I'm going to place my stethoscope and I'm going to put my fingers on your neck just to time myself. Okay, so find the carotid pulse, be comfortable where you feel it. Okay, make sure the patient is also comfortable, and then start auscultating. So I always like to spend about 10 seconds doing a quick auscultation, so listening for the mitral valve here. We come to the left sternal edge and we're listening over for the tricuspid valve. And then here we're listening over the pulmonary valve. And then here I'm listening over the aortic valve. And that just allows me to do a very quick screening of what may be abnormal. Once you've established what you're trying to listen for, then you could practice with maneuvers. So if you want to establish whether there is any mitral valve pathology, or you heard something that you want to explore further, you could ask the patient to turn over. So, sir, can I ask you to turn over and listen in this position by asking the patient to take a deep breath in, breathe in, sir, and breathe out, and hold your breath. And if there is any significant mitral valve pathology, such as mitral stenosis, you'd be able to hear it, and breathe away. Okay, that's absolutely fine. And can I get you to sit forward, sir? Okay, so here is if you're listening for any aortic valve pathology. So again, you do the same thing. Ask the patient to take a deep breath in and out, and hold your breath. And if there was any aortic regurgitation, you'd be able to accentuate the murmur when the patient takes a deep breath in and deep breath out. Fantastic. Okay, thank you very much, sir. Okay, fine. So that's pretty much in terms of auscultation. In this case, what I actually did discover is that this gentleman who's got a scar on his chest, he's also had a tissue pulmonary valve replacement, which you will be able to later hear. To complete your examination, you must check the blood pressure. If there is any observation chart at the end of the bed, you must ensure you check it. So that includes checking the temperature of the patient and also making sure that you've got the pulse rate of the patient recorded somewhere. A urine dipstick is also part of your completion of the examination. To further investigate the patient, you'd offer to do an ECG and measuring the stats of patients, and that would probably be it at this point.